In this video, I'll be talking about pop and chop, which is a supracapsular technique of chopping the nucleus, originally described by Pandit Manweding. So you just witnessed the paracentesis. Here over at approximately 9 o'clock, you're seeing the application of 1% non-preserved lidocaine. Next follows a dispersive viscoelastic to protect the corneal endothelium. Following this will be the creation of a 2.4 millimeter temporal clear corneal incision. You will note that this is a approximately two-step incision, two-stage incision to provide for better sealing. Following this, the bent needle cystotome is used to make an incision in the anterior capsule. Note the placement of the cystotome in the center visual axis, and then the capsule is reflected downwards. Capsular forceps, these are Utrata forceps, are then used to engage and then used to create a continuous curvilinear capsulorhexis. So this is a circular opening by which to access the cataract. Here, the approximate diameter of this capsulorhexis is probably about 5.5 millimeters, close to 6. As a result, this fairly large capsulorhexis was amenable to this particular technique. And you will note during the hydrodissection phase that the application of the balanced salt solution, actually you can see the wave propagating, and then you can see actually the nucleus prolapse out of the bag and into the anterior chamber. So with the nucleus now sitting upwards, I'm placing dispersive viscoelastic, since it has presented itself upwards, both on top of as well as behind the lens. This is to protect the capsular bag as well as the endothelium. And here, this is the phaco emulsification handpiece, which I'm using to smooth out some of the dispersive viscoelastic and now we're using the second instrument, the chopper, to have the phaco emulsification handpiece in the bag. Here you can see the chopper being placed behind the lens, and then these are used in a scissoring motion to basically try to create a small piece. Since this is a fairly soft lens, this is a diabetic, you saw some of the shark's teeth, very cortical type changes, they're very typical with that. This is not a particularly hard lens, and we're trying to get this lens to basically flip over. So you can actually see how really the heminucleus that we've already divided, so that means the top half of this cataract is pretty much gone. One challenge with this particular technique is that the other half of the lens, therefore, is in the bag still, and that we have to engage the remaining half of this material. Sometimes this can be difficult to basically bring up. Here you can see how I'm trying to engage the material, trying to get a particular shelf so that we can actually get this to tilt into the phaco emulsification handpiece, that little tip right at the end here. You can see how there's some areas that are basically trying to come, but we want to do this in a controlled fashion. We also want to protect the capsular bag, which is where the intraocular lens is going to sit. And so here we're kind of teasing, debulking, and as we see, I'm able to gain purchase on one particular area there. Here you can kind of see how the use of the second instrument, the chopper, allows purchase, and here the rest of the lens basically flips up and in, and then this allows me to be able to basically take the rest of the lens almost in total, and so the rest of the lens very quickly and easily basically comes out. Now that we've taken out the endonucleus, the remaining pieces look like epinucleus and cortical material. So changing modes to the irrigation aspiration handpiece and not the sharp phaco tip is safest in this instance. So here we can see the polymer IA tip with that little white little nub, and that's able to very easily remove the remainder of the epinucleus. We can see the brightening of the red reflex as a result. Now the job is to basically try to take out some of these little cortical strands as well as to polish the bag. And so we're accomplishing this by basically turning the irrigation aspiration handpiece, trying to polish the back capsule, take those little strands here, try to get around the anterior capsular rim and see if we can remove some of the remaining lens epithelial cells. So as we're doing that, remembering that we want to try to remove some of them so that we are able to prevent some anterior capsular phimosis or too much scarring that actually can be problematic in a patient who is this young. So she's 50-some-year-old diabetic, type 1 diabetic, and has had diabetes for a long time. She's already had panretinal photocoagulation, a lot of diabetic laser already in the eye, and so here she had the significant cortical changes that interfered with her contrast and certainly night vision. So we're just finishing polishing up the capsular bag, removing the irrigation aspiration handpiece, and then that'll be followed by a cohesive viscoelastic. So we are using this to inflate the bag to permit more easy placement of the lens. So the lens in this case is a Rayner one-piece lens, and this is a preloaded lens. This is introduced using a one-handed technique. The second hand is used to stabilize the eye. In this particular case, we weren't able to get the lens to be in the bag in one go, but we used the second instrument or chopper to basically rotate that into place, and now it is in a vertical orientation, which is really very nice. We can also see how this 6 mm lens has very nice capsular overlap, so that basically confirms that our capsular excess or capsular opening was approximately 5.5 millimeters in diameter. Here we're going behind the lens, as is typical, to try to remove any trapped viscoelastic. Then we're also removing some cortical fragments. We're basically removing the remaining viscoelastic. If we leave too much of it in, it will cause for an intraocular pressure spike on the first day. So we're trying to be very careful and removing the remaining viscoelastic, but this is a very well-centered lens. The Rayner does permit for very good long-term stability of the lens bag complex. Here that is a little bit of the medication that we place in the eye, and now we're just basically hydrating the incisions. So this is again a demonstration of the pop and chop technique, and I hope that's helped you out. Thanks. One more note though. This is the appearance of the eye on the first day after cataract surgery, and this is the 1 week appearance. And as you can see, it's very clear both times.